One of the things we hear a lot about these days is cellular immunotherapy. Is there an opportunity then to harness these regulatory T cells and use them in the clinic?
There's really two potentials for adoptive T cell therapy and transplantation. One of them is using regulatory T cells, and there are around the world that are trying to harness regulatory T cells, both by expanding them in laboratories and then giving them back to patients. The idea of trying to use a chimeric antigen receptor in a regulatory T cell to promote more immune balance.
When you're looking at the mechanisms of graft acceptance or rejection, you're looking at both sides of the coin. The things you're discovering in transplantation are applicable to cancer and to other fields. So that being said, what are the most exciting things that are coming up in this field?
I actually think that the ability to use cellular therapy across the board, so autoimmunity, transplantation, cancer immunotherapy, is extremely exciting. I think that going back to this issue of two sides of a coin, where you have transplantation or autoimmunity, where you're trying to suppress immune function, and cancer or viral illness, where you're trying to augment it. And I think that this kind of approach has benefit in both ways.
So could you maybe talk to us about the role of T cells in things like acute or chronic rejection?
As you know, the real problem with solid organ transplantation of any type is immune rejection. And our bodies are just not set up to accept solid organs from somebody else. And the major barrier to that is T cells. There's all different types of rejection. T cell mediated rejection is a problem that's been mostly overcome by current immunosuppression. It tends to be relatively easily treated, but there's also antibody-mediated rejection, which tends to be more chronic and limit survival of the transplanted organs over a period of time. So it's both a combination of T cell and B cell problems that limits this. One of the exciting things is within the last 15 years, there's another population of T cells that's been identified, which are called regulatory T cells. Their function is to suppress immune responses. So it's really a balance between these two things, T cells that are bad for the transplant and T cells that might be good for the transplant.
I think a lot of the technology and certainly a lot of the training in the cellular immunotherapy field really came from earlier work from bone marrow transplantation teams and the fantastic work that's been done there. Could we talk about how one could move out of a bone marrow transplant model and maybe expand immunotherapy out to be more available?
You need all these facilities to make the cells one way or another, and you either have to be part of a major academic center that has a facility to grow cells, or you have to have a corporation that's able to grow them and ship them. One of the major issues with that is probably going to be regulatory. How you get people to accept cells that were processed off-site and put them back into people. And I think that that's an issue both in bone marrow transplantation and also in any kind of adoptive cell therapy.
So now that we're on the subject of bone marrow transplantation, one of the big challenges is in the post-transplant setting, is how do you reestablish the defensive immune barrier that you've had to deplete to get that graft acceptance? Do you see a role for cellular immunotherapy in that space?
Absolutely. And I think it goes with both bone marrow transplant and solid organ. We have the solid organ transplant has the same issues with Epstein-Barr virus, with cytomegalovirus. In kidney transplantation, we have another virus that we worry about called BK virus. I guess there's a problem in bone marrow as well. Whether you're in a bone marrow transplant setting or a solid organ transplant setting, we have this problem where we've immunosuppressed the patient to a point where they're at risk for these opportunistic diseases, things that our immune system normally protects us from. And being able to specifically target any of these viruses is important. There are current drugs that we use in these patients that are good but not great. They all have their toxicities and side effects. A way to really hit those viruses a little bit more specifically would be more than welcome across the board.